Okay, everybody, I'm going to do this audio tape like I've been doing for you guys, just to kind of hit some of the hot spots and kind of focus you in the right direction with your study guide. For questions 1 and 2, make sure that you turn to page 682 in your book. There's a chart 35.1 and 35.2 that really have more of the symptoms of both left and right-sided heart failure. And there is discussion also on that page, going into the next page, of really how those differ and what actually takes place for those to develop. Often right-sided heart failure, or a patient that has that may have both left and right-sided heart failure. So sometimes people will get that a little bit confused, and I want to make sure you got that straight. I know one of the students pointed out to me that one of the slides from our guest speaker had listed right-sided heart failure with having fluid on their lungs, and our book says that occurs with left-sided heart failure, and that is correct. Unfortunately, some of the patients that she deals with, they really have had left and right, and so the right is where fluid is backed up even further into the periphery, and or the central nervous system along with the kidney system sense this problem and try to hold on to fluid volume, which makes that problem even worse. So thus the importance for daily weighing of patients with right-sided heart failure. Of course, these patients may have quite a bit of edema peripherally, distended neck veins, and when you get some of that fluid off of them by diuresing them while they're admitted, you want to make sure that they really weigh themselves daily at the same time every day, and that is the best and most reliable way of telling whether they are keeping that off. If they were to have a certain spike in weight, that's a symptom that they need to call the doctor and notify them. Another thing with heart failure in general is one of the key teaching things is to have patients learn how to conserve their energy. And most of you probably remember that to a degree. We're going to teach patients to not overexert themselves. They need some regular routine activity that they do so that they don't decline in their capability in terms of activities. But they need to group their things together. If they've got to go into a room for something, they need to, get everything together that they need to do a specific task. They don't need to, add more problems to what their activities are because they haven't planned well for the activities. And that's really kind of what they really mean by energy conservation. In terms of mitral valve stenosis, of course, this is kind of where the valve becomes very stiff and not workable. And your book will clue you in there, but one of the biggest, most common things you're going to see with that is as people exert themselves, they are going to have significant respiratory problems, breathing, short of breath, those kinds of things is a key sign. Why and how long are anticoagulants taken after prosthetic valve surgery? Well, valves, when they're put in and they're not a real valve, they tend to just have a surface area that creates blood clots, okay? Blood to just sit there as sludge and then later get flecked off and create a traveling blood clot. So it is so common for that to occur after prosthetic valve surgery that anticoagulants have to be taken forevermore. And so it's really a surgeon who's contemplating even doing that surgery will really evaluate, is this somebody who can take their meds at the same time every day? Is this somebody that can really be taught? Any dietary issues about taking their anticoagulants that they have to be in control of? And if the person is older, not mentally sound all the time, doesn't have a caretaker that stays with them all the time, more than likely a surgeon is going to refuse to provide the surgery because they can't meet the aftercare that's required. Infection control precautions. Many of these things we talk about, like the itises that are out there, inflammatory infections of the heart, the brain, different things. Some of those require a higher level of isolation. So just look through not just this one, but other ones to make sure you're familiar. Is there anything that you would want to do different for endocarditis, or maybe it isn't? But just making sure that when you hear these different terms, you can differentiate which ones require a specific kind of isolation or don't. In somebody with pericarditis, they are going to have inflammation around the sac of the heart. That feels like somebody is just literally squeezing your heart, and so it's very uncomfortable in terms of pain. Thus, number 9 talks about the radiating pain that goes along with that. And that pain is significantly worse if somebody is laying flat, because it's just like downward pressure that is making the pain worse and worse. So if you have that issue going on, you want to make sure that you really try to sit the person up, lean them forward, and if they need pain medication, see what you can provide. But that you want to make sure that you have kind of evaluated. There is also a specific kind of symptoms that you would see with pericarditis when you are listening to heart and lung sounds. So I will clue you into that. What kinds of heart sounds would you maybe experience as a normal thing? And what would you expect in terms of that person's heart rate? If it's being compressed, would the heart rate be struggling to be up or down? Just things like that to kind of think about. And then how would the lungs sound on that patient? Let's see. And then with mitral valve regurgitation, this is where the valve is really not holding solid. It's kind of flapping in the wind. There is a specific kind of dysrhythmia that's associated with that, and you want to know what that is, because that particular arrhythmia requires treatment with medications to control it. So if you have that kind of patient, you want to be prepared to know what that is so that you can know how to handle it. Let's see. I know that in the lecture from the guest speaker, we talked a little bit about pacemakers and automated implanted cardiac defibrillators. Just to kind of differentiate between those two, the pacemaker is used when the electrical function of the heart is not working properly at the SA node, or it may also be because the SA node is firing, but because the damaged heart muscle is not really allowing all the beats to travel their normal pathway, and so they're not all ending up with a ventricular contraction. So they may need to kind of bypass the normal electrical activity to pace the heart so that it really does do what it's supposed to. Sometimes that's necessary with a diseased heart, but also sometimes patients that develop different, like ventricular tachycardias or PVCs or ventricular fibrillation really do require some immediate change to shock their rhythm back into place. And that's why, when you went through CPR, you learn about putting somebody on an AED and letting it determine the rhythm and shock them as soon as you can. So the beauty of the AICD is, though, a lot of them have dual functionality. So if somebody has problems with both electrical pump and the potential for having those arrhythmias, they can actually have one that has dual functionality. All right, in terms of low back pain, I think we covered that in class very well. Just kind of knowing what the risk factors are, how do you prevent back injuries, and then like how do you really treat those properly. And we talked about ice is really kind of a treatment sometimes that's used more often for initial injury, but for long term, the beauty of heat really is that it like opens up the blood vessels and maybe soothing, as well as increased circulation that is good for promoting healing. Let's see. Typical complications to assess following a discectomy. If someone's having disc surgery, we showed the braces and things that are required to be worn when you get somebody up. But most often they're going to have to wear those braces because their muscles are so weak back there and it takes a while for them to build those back up. They may well have to be in a brace anywhere from 3 to 6 months. And so making them aware of that and making sure that people are compliant with that so that further injury doesn't occur is very, very important. Obviously, they're going to look for signs of infection and all the typical things that you do post-operative, but that brace is like one of the major functions of safety for somebody. Complications, we talked a little bit about the anterior cervical discectomy and fusion, and remember they go through the side of the throat to get to it on the front side to get to the bones on the back side. And so remember all the things we talked about. Respiratory complications due to swelling, can cause the airway to cut off. You may see differences in breath sounds. They may have stridor or weird sound in breathing. Some of your typical symptoms that you would know that was a key issue. All actions to take for autonomic dysreflexia, those are covered very well in your book. And the key thing to take away from that is always look for the cause. You really want to look what is causing this so that we can get this stopped immediately, because it is some type of sensory cause that is usually at the root of it, and if that's removed, then usually the symptoms will gradually decline and become less emergent. Priority actions to take for a spinal cord injury. You want to make sure that like we said before, really looking at what are we trying to safeguard from somebody that is having a spinal cord injury, and putting them in alignment, making sure that depending on where on the spinal cord the problem is very key, because the higher up it is, the high L's and the anywhere in the cervical spine, really can lead to all of the complications that we talked about in terms of, respiratory status, cardiac status, and all those kinds of issues. Your book goes into a lot of detail in terms of some specific suggestions on a bladder and bowel program. There are questions about both of those, so make sure you're familiar with those. And paraplegia, patients often will be very despondent after having an injury that ends up with paraplegia. And so, as you can imagine, a lot of them need a lot of emotional support to really get them to where they will want to go and participate in rehab programs. But making sure that they understand that is important, but not to be too prescriptive. But the main thing is they have to learn how to relearn to maintain the functional ability they have, and while not losing ground and not getting into further disability. And again, here's the question about the bladder control. Just make sure you're real familiar with both bowel and bladder and the ways that you go about improving that in somebody and teaching them regarding